Right, good morning, everybody. Welcome. Today is Journal Club, and Dr. Phillip is going to present data from the FAME-3 trial.
Perfect. Thank you, Dr. Adran. So I wanted to talk about the FAME-3 trial. It was published, or it was first presented at TCT in the fall of last year. And I think there's some important updates to go through and stuff that's pertinent to our everyday practice. So let's see. All right. So, we know from trials such as Syntax and Freedom that, CABG has improved outcomes in patients who have multi-vessel coronary disease when, we compare outcomes to PCI. And most of these trials, they use bare metal stents, or they use the first generation drug-eluting stents, such as the Taxa stent, which was a paclitaxel drug-eluting stent. These studies, they did not compare FFR-guided PCI with CABG, and it was more based on, angiographic appearance of lesions. So, just briefly, this is from the Syntax study that was published in 2009. You can see here that there were greater rates of MACE in patients who underwent PCI, 17.8% versus those in the CABG group, about 12% or so. And a lot of this was driven by repeat revascularization at 1 year. And so I go through that because the way that the people who designed this study, they really wanted to compare this to the Syntax trial in 2009, and they wanted to see if they could get kind of different results. So their question was to evaluate the performance of FFR-guided PCI with current generation stents, which are, in this study, it was the Zoeterolimus drug-eluting stents, as compared with CABG with respect to, major adverse cardiovascular or cerebrovascular events in patients with 3-vessel disease. And they hypothesized that FFR-guided PCI with these current generation stents would be non-inferior to CABG at 1 year. So the things that make this study unique, again, are that the second generation stents that we use today, they have lower rates of stent thrombosis, procedural MI, lower rates of restenosis, and death. And then we know from other studies by, the people from the FAME trials, they've showed that, FFR-guided PCI results in improved short and long-term outcomes, angiographic lead-driven PCI, and also medical therapy by itself. So those were the kind of things that make this study special. So, in terms of the trial design, they enrolled 1,500 patients. They were from about 50 sites all over the world, Europe, North America, Australia, and Asia. It was randomized, it was controlled, and it was a non-inferiority study. This was a study that was supported by research grants from Medtronic and Abbott, and the data was collected by folks at Stanford University, and Dr. Bill Fearon, he was the one who kind of led this study. Patients with 3-vessel disease were randomly assigned to undergo CABG or FFR-guided PCI. You can see, there was about 750 groups folks randomized to each arm, and there was very little kind of crossover, and then there were a few people who were lost to follow-up. So in the end, there was 757 folks in the PCI analysis, and then 743 in the CABG. And the patients were stratified according to their diabetes status and the trial site. So, I'll go through inclusion criteria and exclusion criteria here. So, they had to have 3 vessel disease. They had to have at least 50% diameter stenosis in 3 major epicardial arteries or the major side branches. And there had to be, a heart team approach. Everyone had to agree that, the patients would be amenable to revascularization by either PCI or CABG. And then, the main exclusion criteria you can see here on the left, left main disease, they excluded patients with recent STEMI within 5 days of the procedure. Cardiogenic shock patients were excluded, and patients with an EF less than 30%. So really like the sickest patients kind of that we can, take care of. And then, if you look at the supplemental data, they did have some other notable things that we see not infrequently. So if the patients had, an indication for other surgical procedures, such as a valve or like aortic intervention, they were excluded. Patients who required renal replacement therapy, so end-stage renal disease patients, were excluded from this study. If they already had a target lesion with instant drug-eluting stent restenosis, they were excluded. Kind of makes sense because, they've already failed it, I guess, once, if you will. And then more than one major epicardial vessel with a CTO. So more than one CTO, those patients were excluded as well. Their primary endpoints, they looked at MACE at 1 year, so that was all-cause death, MI, stroke, and repeat revascularization. They also had secondary endpoints, which was a composite of death, MI, and stroke. And then they also looked at safety, such as need for repeat rehospitalization in 30 days, arrhythmias. They looked at AKI and major bleeding. So I'll go into that data in a few slides. And then, in terms of statistical analysis, based on, what they calculated, the non-inferiority margin was set as a hazard ratio of 1.65 in this study, and that's what they used. So in terms of trial procedures, the patients who were assigned to CABG, they recommended complete arterial revascularization as much as the operators felt comfortable. They really did want everyone to get a lima, and then they kind of left the other conduits, to whatever the surgeons felt most comfortable with. And then, if FFR was done before CABG, then the information could be used by surgeons. Most of the patients in the CABG arm did not have FFR data. And then they recommended that the patients be on aspirin, statin, and other guideline-directed medical therapy. In terms of the PCI patients, the FFR was done in for most of the lesions. It was done with an Abbott coronary pressure wire. If the FFR value was less than 0.8, it was treated with PCI. And they used Medtronic Resolute Integrity stents in this study. They did encourage post-PCI FFR. They left the use of IVUS or OCT imaging to the discretion of the interventionalist who's doing the procedure. And they recommended that the patient be on an aspirin, statin, and a second antiplatelet agent for at least 6 months. They obtained a troponin, a hemoglobin, a creatinine within 12 to 24 hours after the procedure. And they followed these patients at hospital discharge at 1 month, 6 months, and 12 months. And this is from the supplemental data. You can see here, most patients were on aspirin in both groups. You may be interested in what was their second antiplatelet agent. Most patients in the PCI group were on Plavix. And then after that, it was ticagrelor, and the least number of patients were on prasugrel. But there was it was used in a small fraction. And most of the patients in the CABG arm, were not on a second antiplatelet agent, but some of them were, as you can see here. And then most patients were on a beta blocker, and then other anti-anginal medications. And then, most everyone was on a statin. And, they pointed this out, in the paper, that this number of like over 90% of patients on a statin is really, really high. And it's different from what they found in Syntax, where about only 70% of patients were on statin. So really, everyone did very well with guideline directed medical therapy here. In terms of patient characteristics, the average age in both groups was 65. Most patients were male, about 80% were male, and over 90% of patients were Caucasian. Other notable features we should kind of go into are that about 30% of patients were diabetic. About 15% of patients in both groups had had previous PCI, and a small fraction, about 20%, had an EF less than 50%. So really, most of these patients had preserved EFs. And then probably important to note that, the group of patients with ACS, it was about 40% in both groups, in the PCI and CABG groups. And then, to go into angiographic and procedural, specifications. So you can see here and as expected, the median length of hospital stay in the PCI group was 3 days as compared to 11 days for the patients who underwent CABG. There were about 20% or so of patients who had at least one CTO in the PCI group and in the CABG group. And then, bifurcation lesions were also found in a good number of patients, about 65% in both groups. The average Syntax score was 26. So similar to what they had in the original Syntax trial as well. I think their average was 28. So most of the patients had kind of intermediate level of complexity of disease here. And then, after that, it was probably low Syntax scores at about 30%. And, the very most complex, it was about 18% or so in both groups. So first I'll talk about, the PCI characteristics. On average, patients received, 3.7 stents for, multivessel coronary disease. The median total length of the stents was, I guess a little over 20 per stent. And then this is an important thing to note here is that, IVUS was used in about 12% of the cases. And then I think it's probably also important to mention that, they measured FFR in 82% of all of the patients who underwent PCI. So, a substantial portion of those patients had FFR. The most common reason why they, didn't measure it was if the lesion was like a subtotally occluded lesion or if it was CTO. So in those instances, they did not measure the FFR. The average FFR was 0.7, so, significant. And, only a quarter of them, had an FFR that was greater than 0.8. So, those are the patients that did not have PCI at those lesions. And, they had encouraged the operators to measure FFR after, and 60% did. And the mean there was 0.88. So, most were not, were kind of hemodynamically insignificant after the PCI. And then, to look at the CABG group, I think the big thing here is that 97% of the patients did get a lima. And even probably the average number of distal anastomoses was 3.4. So, between 3 and 4, that's kind of, I think, what we see in practice. And then multiple arterial grafts, were used in a quarter of the patients. And then, the other probably important thing here is off-pump surgery was done in about a quarter of the CABG patients as well. Oh, and then I'll just mention here briefly that, FFR was done in about 10% of the patients before PCI, and that data was available to the surgeons when they were doing CABG. So here are the results of this study, and that's that, for these endpoints of death, MI, stroke, and repeat revascularization, the PCI group had a greater number. It was 10.6% versus the CABG group, which was 6.9%, and that was at 1 year. So, it did not meet the criteria for non-inferiority in this study. And then, it's important to look at the safety endpoints, which were looked at, their secondary endpoints. And so at 30 days, you can see here's the blue, which is the PCI group, and then red, which is the CABG group. And so for major bleeding, and arrhythmia, AKI, and rehospitalization within 30 days, CABG had a significantly higher number of, safety endpoints than did the PCI group. So something to kind of, things that probably are intuitive to us, but that can, affect patient quality of life and things like that. So here's a, forest plot that looked at certain subgroup analysis. So they went and looked and broke up these patients according to age, sex, diabetes, the presence of ACS, EF, previous PCI, and syntax score. And what they found was really the only group that did better with PCI here was, the low syntax score patients, which, we've seen before, and, maybe probably kind of consistent with the way we practice and see things in clinical practice. So this is the, just a graph showing you the details here, but basically in the low syntax score, so patients with a score less than 23, you can see the CABG group has greater rates of MACE than the PCI group. And then when you go into the intermediate syntax score and the high syntax score, that flips. So PCI has greater rates of MACE in the intermediate and high syntax score groups. So, the people who put together this study, have had about 5 conclusions here. So I'll go through them one by one here. So, the FFR-guided PCI with second generation stents, they did not meet the threshold for non-inferiority when compared with CABG for outcomes of death, MI, stroke, and repeat revascularization at 1 year. So again, the numbers were 10.6% in the PCI group compared with 6.9% in the CABG group. The 1-year rate of death, MI, and stroke was not significantly different between the two groups. You can see here, so, mortality, MI, and stroke, they're pretty much superimposed. Repeat revascularization had the biggest difference. It was PCI group, it was 5.9% versus CABG, 3.9%. So, kind of similar to what they found in the Syntax trial, just that the absolute numbers are much lower in this group. And, this is kind of the graph that shows that nicely. So, they wanted to kind of show that the characteristics of the patients in FAME3 in this study were very similar to the patients that they, looked at in Syntax. And basically, from 2009 to 2021, we're both doing much better in both the PCI and CABG groups with respect to event rates with MACE. So, it's down from 12.4% to 6.9% in the CABG group. And again, the PCI group did better than the CABG group in 2009. So, and then things that I think we probably already know in practice are that FFR-guided PCI with second generation stents did perform well in the low Syntax score group. So maybe something to continue to tell our patients that, potentially if you have a low Syntax score, we can get away with PCI for you. And then finally, in the intermediate Syntax scores, so anyone with a score greater than 23 and the high Syntax score groups, we should probably continue to reserve CABG for those patients with more complex disease. So, I'll just kind of touch on some of the limitations here as my last slide. So, the follow-up analysis in this study was for 1 year only. They talked about how, if we had longer follow-up, potentially that may be even better for the CABG group. And they're going to look at this in, for 3 and 5 year follow-up data. So there's more to come here. They did include about, 30% of the patients had diabetes, about 18% had an EF less than 50%. So, currently we kind of tend to recommend CABG for these patients. And so, maybe this skewed the results in a certain way. So that's, something to consider as well. They did not talk about quality of life or cost effectiveness in this study. I think Dr. Fearon is going to be presenting that data at ACC in a few weeks this spring. But that's something to, that's really important to our patients. And, if it means potentially needing an additional cath and PCI, versus having a sternotomy, patients may prefer that, if that's important to them. FFR is not done routinely in the CABG patient group. I think you would think, based on what we know about outcomes with PCI, potentially, CABG patients would also do better, although studies have shown that FFR-guided CABG is not better than, angiographically determined kind of bypasses for CABG patients. So that's something I think that Dr. Fearon and his colleagues want to look at in the future as well. And then I think probably the big thing here, IVUS was only used in 12% of patients who underwent PCI. And, the study was designed in 2012 and 2013 when the data for intravascular imaging was not as robust as it is now. And I think that is one of the things Dr. Fearon said he would, potentially change in the future, is encourage intravascular imaging. They have not looked at completeness of revascularization, and I think that that's something else that they want to look at, specifically patients, with CTOs, because they made up about 20% of the population. And so, if if that affected kind of the outcomes, then that's something to potentially look at. That maybe CABG was better in this study because of that. And then finally, this was mostly Caucasian males who were, in their mid 60s, were studied in this trial. And so we're not sure if we can really generalize this to women and minorities. So those were the things that, I wanted to present. I'll welcome, anyone's thoughts on the study.
Thank you, Cynthia, for a wonderful and clear presentation with great slides, and you really nailed down the key findings and the limitations, such as only around 7% non-white, 18% women enrolled, and of course the low usage of IVUS. And it is interesting that I don't think they really clarified whether the CTOs, which were around 21%, were attempted or revascularized or not. I wasn't sure if I saw that.
They didn't. No,
They didn't.
that's
Okay,
something
yes.
that they want to look at in further subgroup analysis.
I see. Yes, thank you. And I think one point that Will Fearon also conceded is that because the non-inferiority was not the primary endpoint, was not demonstrated, the idea that the lower syntax group, the 22 and under syntax score group, appeared to do better by PCI is only really hypothesis generating, and it is not conclusive.
Yeah.
Any thoughts or comments from the audience?
Hi, this is Samit. I think this is just another example of how ischemia-driven revascularization does not really change your prognosis. And so it might be better for symptomatic relief, but prognosis is really determined by the anatomic burden of disease. Cynthia, do you remember what the post PCI FFR was in that fraction of patients where it was measured?
Yeah.
Was it 0.88?
It was 0.88. Yep. It was done in 60% of the patients who underwent PCI after. I mean, it was 0.88.
Yeah, and so this is kind of, people have reported this with FFR, and then obviously Defined GPS is looking at this too, that, it's a moving target. The higher you can get that number, the better your outcomes, presumably. So I think, between the post-PCI FFR and then incorporating intravascular ultrasound, you could really maximize the outcomes of PCI, but I still don't know if it would ever beat CABG, because things like, as Rob said, that there were 21% of CTOs that were attempted or revascularized because the anatomic burden of disease was so high.
Yeah, that's a good point, Samit. Any other questions or comments from the group?
Yeah, Rob, hey, this is Steve. I just want to point out that, first real systematic evaluations of CABG versus PCI, the Barry trial, which I think was funded by the NIH. Their 5-year results were reported in 1996. And the revasc rate in the angioplasty arm in that trial was over 50%. So now we're down to much improved, still not beating CABG, but certainly dramatically different. So angioplasty has really come a long way. And interestingly, even at that time, balloon angioplasty with a restenosis rate, repeat rate revascularization rate of 50%, prognosis was not affected. In other words, an initial strategy of multivessel PCI did not make more people died. So I think that's to Samit's point as well, that this is a disease management strategy and a symptom strategy, but it's not going to affect people's prognosis either way. So I don't think we should get too upset that our numbers don't beat surgery.
Does the group think that this population generally translates to the people that we see? Because these patients are the ones that could either go for CABG or PCI, and I think the mean syntax score in the study was 26. I mean, are these our patients?
I mean, they're definitely not the patients I'm treating in the cath lab. In my experience, since I've been here, most patients who have, equipoise or are considered relatively low risk for bypass surgery go for bypass surgery. And the patients who come to the cath lab are the surgical turn downs. I think that certainly at Yale, most of these patients, from what I can tell from the trial, would be actually treated with bypass surgery at the moment.
Right.
I mean, I think, Rob, you can look at the actual just readmission rates as a marker of sort of the unmeasured comorbidities of the patient population. And, 5% readmission rate for PCI is less than half of what we typically see. And so that's, I think, suggestive, like as in all clinical randomized trials, it's selected group of patients that may not be representative. That said, for that group, I think the findings are certainly internally valid. The other piece is that, I guess maybe Cynthia, you may have mentioned this before I got on the call, but the selection of revascularization as an endpoint at 1 year is of dubious clinical merit, right? I mean, if you did a standard gamble conversation with patients about what would they rather do, a 5% increased risk of a repeat PCI within a year or having their sternotomy, it's ambiguous which one they would choose. I know which one I would choose.
Right.
Yeah, I couldn't agree more. And, it's been studied and demonstrated that patients really don't particularly care about repeat revascularization. Their number one priority when you ask them is avoiding a stroke. And then the number two priority is being alive. And I don't understand why, this slide that's up now shows a whole host of other factors which favor PCI: bleeding, AF, AKI, rehospitalization. I don't understand why repeat revascularization should be incorporated into the primary endpoint above any of those things that are listed here. And I think if repeat revascularization wasn't in the primary endpoint, then the difference wouldn't be significant. I think Cynthia showed that on one of her slides.
Yeah, I wonder if it was just a power calculation issue that they needed to boost the endpoint to be able to keep the population size within their budget.
Yeah, I think that's what they mentioned in their methodology. And they're following this data out to 5 years. So it'll be interesting to see if there's further division in these harder endpoints further down the line.
And I think you really need to follow these patients for 10 years, ideally, because between 5 and 10 years is when you may start to see vein graft failure. And most of the data we have for long-term doesn't suggest, differences in mortality even at 10 years between CABG and PCI. So I hope they have 10-year follow-up. Cynthia, can you tell us what was the MI definition used in this study?
Yeah, so that was important. Here, so they use spontaneous MI, which is kind of what we're more used to, and they used MI related to revascularization, and that was based on the third universal definition of MI, where they have kind of stringent criteria where you have like a rise in the troponin along with new Q waves and new potential wall motion abnormality or angiographic evidence of a graft occlusion or a vessel occlusion. So those were the things. And that was something that Dr. Fearon had mentioned in some of the videos and in interviews, is that if they had used a more liberal definition of MI, like the SCI definition of MI, then the patients in the CABG group would have had more MI than, the PCI group. So that is an important distinction here. Let me try to show you.
I think while you're looking at that, the other thing that does crop up is the bias towards repeat catheterization and revascularization in patients who have had PCI. The cath proportion of those patients is far higher than the post-surgical patients. In addition, when many patients are grafted and the graft goes down, the vessel frequently has progressed to a CTO, again, biasing against intervention in those patients, even if they're CAF'd.
This is a PCI or CABG related MI less than 72 hours. It's an elevation of the cardiac troponin, along with new Q waves, angiographic evidence of graft or artery occlusion, and then, loss of viable myocardium or regional wall motion abnormality. That was their PCI or CABG related MI.
Cindy, that's just the third universal definition, right?
Yeah. Exactly.
Any other questions or comments from the group?
I guess the thought about long-term follow-up is interesting, especially in terms of vein graft failure. It would have been nice to see how many people had physiologically significant disease who went for CABG, or more of those patients. Syntaxes showed that there was an ongoing survival benefit in people who had CABG over PCI. So I don't know. I mean, the long-term follow-up would be really interesting for this study.
Yeah. Well done, Cynthia. Thank you, everybody. Great job. Have a great day, everybody.
Thank you.